Good afternoon, everyone. My name is Janice Whitaker, and it's my pleasure and privilege to serve as the administrator and community liaison for CGNE. It's also my pleasure to host this seminar series, and I'd like to introduce Jenny Rank, our CGNE Education Program Specialist, who is very instrumental in implementation of this series. The program's being provided by the Tressa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Ross and Carol Neese College of Nursing at Penn State, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age Friendly Care Pennsylvania. Today's seminar, Diabetes Management in Older Adults, will be presented by Dr. Michelle Boakye, a current postdoctoral fellow at Villanova University. Michelle also earned her doctoral degree at Penn State and was one of our center's grad student affiliates. So we welcome her back to Penn State. Before we begin the presentation, we do have some disclosures and announcements. So Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. So participants with a valid RN license who attend the entire Nursing Continuing Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. This topic of education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. So in order to earn contact hours, we do record attendance, and we do require that all RNs, and appreciate if all participants complete the post-event evaluation, which will be available to you via a link at the end of the session, and it will also be emailed to you within 24 hours. It does need to be completed, preferably within a week, and your certificates will be sent to you within a month of the session. The seminar today is being recorded. If you have any questions, you can enter them into the chat feature, and Jenny will keep an eye on that. She'll also keep an eye on the raise hand feature, so you can be unmuted if you prefer to share a comment or ask a question aloud. Again, we will share the post-event evaluation towards the end of the session, and we appreciate it if everyone completes that to provide feedback not only to the speaker, but to us about our seminar series as well. If you have any questions, please feel free to reach out to us at cgne@psu.edu. Next, I'd like to introduce Jenny Connect Frito, one of our current CGNE PhD student affiliates. As an advanced practice nurse, Jenny works at Memory Care Community. She's also a very important member of the Age Friendly Care Pennsylvania initiative within our college. And Jenny already contributes so much to our center's mission, but we look forward to her continued scholarship. Thanks for introducing our speaker today, Jenny.
Thank you, Janice. So Dr. Michelle Boakye is a registered nurse with over 10 years of both clinical and teaching experience. She earned her Bachelor of Science degree in nursing and her Master's of Public Health from the Kwame Nkrumah University of Science and Technology in Ghana. She recently graduated from the Penn State Ross and Carol Neese College of Nursing with a PhD in nursing. Dr. Boakye's research interest includes person-centered diabetes care and diabetes self-management and support. She is a 2022 Association of Diabetes Care and Education Specialist Foundation mentored postdoctoral fellow in integrated diabetes management at Villanova. Her current study is focused on developing and testing the feasibility of using a web-based tool to assess and identify the immediate concerns of individuals newly diagnosed with type 2 diabetes in health disparity populations. Welcome, Michelle. We're so glad to have you back.
Thank you, Jenny, for that nice introduction, and it's good to be back. Today marks the last day of my postdoc at Villanova, and I'm glad that I'm having my last postdoc presentation at Penn State, where all my diabetes research began. So it's good to be back, yes. And I'm going to share my slides now. Do you see my slides?
Yes.
Okay,
Yep,
great.
looks good.
Yeah, so as introduced today, I will be talking about the management of diabetes in older adults. And for this presentation, I will discuss some of the challenges associated with diabetes management in older adults, as well as current diabetes management practices. And lastly, talk about notable diabetes clinical and research gaps when it comes to the management of diabetes in older adults. And just to give you some context regarding the burden of diabetes in the US, there are currently about 37.3 million people of all ages living with diabetes in the US. And this is approximately 11.3% of the entire US population. Out of this figure, about 29% are older adults with diabetes. And this is because diabetes is a highly prevalent condition in the aging population. Compared to adults aged 18 to 64 years, the incident rates of diagnosed diabetes are higher among adults aged 65 years and older, with about 9.4 per 1,000 people diagnosed each year. And this figure is even expected to increase rapidly in the coming years. All these statistics are alarming, given that diabetes is associated with life-threatening complications such as stroke, kidney diseases, cognitive decline, and many more. Aside the life-threatening complications, diabetes places a huge financial burden on the individual, the healthcare system, and the country, as it's the most expensive chronic condition to manage now in the US. An analysis of the economic cost of diabetes in 2018 indicated that the total cost of diagnosed diabetes have risen to $327 billion from $245 billion in 2012 when the cost was last examined. This same report also shows that approximately 61% of all the healthcare costs attributed to diabetes in the US were incurred by older adults. Now, when it comes to the types of diabetes in older adults, type 2 diabetes constitutes approximately 90 to 90% of all diabetes cases, similar to what is found in the younger population. However, improvements in insulin delivery technology and diabetes care over the last few decades have led to increasing numbers of people with childhood and adult onset type 1 diabetes surviving and thriving into their later decades. One reason for the increasing prevalence of diabetes in older adults is the strong association between increasing age and type 2 diabetes. Type 2 diabetes is characterized by hyperglycemia, and the aging contributes to the pathogenesis of type 2 diabetes, both directly through the decreased beta cell function that accentuates the lack of insulin secretion, and indirectly by increasing insulin resistance through obesity and other risk factors. It is important that we manage diabetes in older adults because they are at higher risk for both acute microvascular and macrovascular complications from the condition. Not only that, older adults with diabetes have higher rates of premature death, functional disability, accelerated muscle loss, and coexisting illnesses such as hypertension, coronary heart disease, and stroke than those without diabetes. Lastly, older adults with diabetes are also at greater risk than other older adults for several common geriatric syndromes such as polypharmacy, cognitive impairment, depression, urinary incontinence, injurious falls, persistent pain, and frailty. These conditions may impact older adults' diabetes self-management abilities and quality of life. Hence, it must not be left unaddressed. Due to these distinctive features of older adults that I've mentioned and the heterogeneity in their medical, functional, and cognitive status, it is recommended that treatment regimens are individualized to meet the needs of all older adults with diabetes. So it is important that comprehensive geriatric assessment of clinical, psychosocial, and functional factors are performed when setting glycemic goals and planning treatment strategies, which should be centered on the individual's needs, preferences, and risks. With diabetes management in older adults, 3 groups are usually defined for the purposes of allocation recommendations. I know in most geriatric groups, we talk about older adults as those 65 years and older, but when it comes to diabetes, we use these 3 groups for allocation recommendations when managing diabetes in older adults. The first group are individuals in good health with little or no functional impairment and long life expectancy, that is 10 years to 15 years and above. And the second group are those with comorbidities and mild disability with intermediate life expectancy, while the last group are those with high comorbidity and disability and shorter life expectancy of, let's say, less than 5 years. With this brief background, I'll proceed to look at the current diabetes management practices in older adults and the research gaps, given that we do not have detailed information from diabetes clinical trials involving older people with varying characteristics. This slide shows the American Diabetes Association's recommended test and diagnostic criteria for diabetes. When it comes to the screening and prevention of diabetes in adults, this is what is mostly used in the US, even though there are other screening guidelines like the International Diabetes Federation and the World Health Organization screening guidelines for the screening and prevention of diabetes, not just in older adults, but this is something that is used for the entire population. So although large data sets have found that the mean glycemia increases with age, these guidelines do not have age-specific criteria or recommendations for screening frequency based on age. For example, in adults aged 65 years and older without known diabetes, fasting plasma glucose or A1C screening is recommended to diagnose diabetes or pre-diabetes. However, data suggests that if only fasting plasma glucose or an A1C is done to screen for diabetes in older adults, a substantial number of people with impaired glucose tolerance, which refers to glucose levels above normal, but not up to the diagnostic point for diagnosing diabetes, these individuals are likely to be missed because the measurement of H1B, A1C may be inaccurate in some older adults because of comorbidities that can affect the lifespan of red blood cells in the circulation. Although the optimal screening frequency for people whose initial screening test is normal remains unclear, the expert committee advocates repeat screening every 2 years thereafter. So that could tell us that if someone's blood glucose is normal now, and then it's going to be repeated within 2 years just based on an A1C, and they have issues that I've talked about which affect red blood cells, it's very likely that the diagnosis of diabetes or impaired fasting glucose will be missed. However, if an OGTT, which is oral glucose tolerance test, is performed, it may diagnose diabetes in some individuals who were otherwise diagnosed as having impaired glucose tolerance or normal glucose levels by other screening levels. However, How such a diagnosis or its treatment would alter clinically meaningful outcomes in an older population is unclear. And important knowledge gaps such as the age-specific criteria for the diagnosis of impaired glucose test, pre-diabetes and diabetes is still unclear. And there is a need to find the best method to screen for diabetes in older adults and the role of the oral glucose tolerance test in varied settings, since it is currently not being used for those who test negative for diabetes when we use A1C or fasting plasma glucose. There is also the need to investigate the impact of intervention on clinically meaningful outcomes after screening individuals and then they test negative for diabetes. Another challenge of managing diabetes in older adults is that the condition is frequently accompanied by multiple comorbidities. Based on concepts such as competing mortality and lag time to benefit, classifying older patients by comorbidities has been viewed as an important way to individualize the intensity and the approach to diabetes management. I've already showed you the 3 classifications that we use when it comes to the management of diabetes in older adults. And these are some of the studies that led to those classifications. However, despite the evidence which shows that it is important for us to manage diabetes in older adults based on these groupings, there are important knowledge gaps related to comorbidities in diabetes. At present, we do not have a reliable comorbidity classification system that identifies clinically distinct subgroups of older patients. When you look at the 3 main groups, it's just a broad definition that is given under each. Therefore, there is the need to have newer classification systems that would incorporate additional independent variables such as frailty and the severity of the conditions under each of these groups. And the new classification should even be externally validated beyond the original development data set. Furthermore, evidence is needed regarding optimal targets for glycemic control when it comes to management of diabetes based on this group. The third challenge I'm discussing today has got to do with setting glycemic goals, because achieving optimal glycemic targets in diabetes management can help delay or prevent the onset of most of the long-term complications that I've already talked about. However, because microvascular complications develop over time, and for many older adults with a limited lifetime life expectancy, intensive glycemic treatment will offer no net benefit. Hence, factors such as the functional status, the comorbidities, life expectancy, social factors, and patient preferences need to be considered when it comes to setting glycemic goals. Unfortunately, in the US, many older adults with diabetes are being overtreated. For example, it is reported that about 50% of older adults with diabetes have an A1C less than 7% while using insulin or sulfonylurea, regardless of their functional status. And this creates a potential for harm, particularly with the accompanying burdens of the treatment, such as polypharmacy when it comes to monitoring of blood glucose or even the insulin that they are supposed to inject in these older populations. The heterogeneity of older adults with diabetes raises the issue of using A1C targets in diabetes management. Now, A1C is the gold standard for measuring whether diabetes, you are managing the condition properly or not. But when it comes to older adults, there's still issues when it comes to using these targets for management, because as I've already said, many older people with diabetes have conditions that alter red blood cell lifespan, such as anemia, making the A1C a less reliable measure of glucose control. Hence, an alternative to A1C as a glycemic target, especially in populations with high prevalence of conditions which will affect the red blood cell, is needed. Again, it is important that we investigate the impact of certain A1C target levels on other outcomes, such as functional deterioration, cognitive impairment, falls, institutionalization, hospitalization, and premature deaths, as this has not been studied in detail. What is currently being done is that a lot of people are just given specific A1C levels, and that is the goal. But then what if we set the target A1C range such that individuals could either be between the 7 or 7.5, just as an example. But studies have not shown the impact of using this target range on whether we are able to achieve optimal diabetes outcome in individuals, especially older adults. Lastly, there is a need to examine clinical decision support, such as shared decision-making, electronic health records, decision aids, and clinical reminders, and even quality measures to track potential overtreatment of diabetes in older adults. In my previous slides, I did talk about the increasing prevalence of older adults with type 1 diabetes. However, older people's experiences of aging and how it affects their diabetes is not well understood. Such an insight will be important in understanding the issues older people with type 1 diabetes face. In addition, as older people become less independent, their reliance on formal and informal caregivers will definitely increase. So identifying the perspectives of relatives and caregivers would also be needed when it comes to the management of diabetes in older adults with type 1 diabetes. Also, studies should look at the role of newer technologies used by older adults with type 1 diabetes, such as insulin pumps or continuous glucose monitoring devices in various settings. We know that there are a lot of older adults in various settings, but then no study has been able to tell us the role of these new technologies being used by older adults in such healthcare facilities and how that can impact their clinical outcomes. Despite good evidence in younger individuals with type 1 diabetes with respect to the efficacy and the safety of insulin pump use, there is limited data for those over the age of 65, as many of the randomized control trials excluded older people. It is also not clear if the existing data with respect to the use of insulin pumps and CGM, which is a continuous glucose monitor in aging populations, may be generalizable to individuals with cognitive and functional deficit. I've already talked about the fact that comorbidities are not the same and older adults are different. So we don't know this, whether the findings that we have with individuals, older adults using insulin pumps and CGNE in aging populations could be the same as those with cognitive functional deficits. More data is equally needed to understand how caregivers can facilitate the use of technology used by older adults. And finally, we need more studies on the development, design, and efficacy of educational training programs for the use of technologies in older adults and their caregivers. My last clinical and research gap in diabetes management in older adults has got to do with the significant shortfalls in our knowledge of care home residents with diabetes, especially those in long-term aged facilities, particularly those with diabetes in palliative care settings. It has been recognized for some time that for the residents of the long-term facilities, there is little evidence of structured diabetes care or clear oversight on the safety and efficacy of different treatment regimens. And I had an experience when I practiced as a nurse in a nursing home. And even though I was passionate about diabetes management, I did not really get the opportunity to put into practice all that I know about diabetes management, because at the end of the day, what they are interested in is that I finish my job as a nurse and not be there as a diabetes educator or a diabetes advocate. And I saw how that kind of influenced the way the residents responded or how they even view diabetes management. I had several experiences where I saw residents keeping meals because they felt they didn't like the food, and then they had to fall on the snacks in their room. And all these things have to be studied, because the facility that I went to, there wasn't any structured diabetes care. No one gave me any orientation or told me that this is the guidelines that we use in this facility. It's all about, you are the nurse on the floor, this is the medication, you administer it, and you don't even have time to provide any kind of diabetes education, which we know it's also important when it comes to empowering the individuals and when it comes to proper self-management. Furthermore, there's also limited descriptive information for end-of-life adults with diabetes. A lot of studies have not been done in this area. We don't know how people at that stage of life deal or handle diabetes, as well as their caregivers. Some of the adverse diabetes outcomes in long-term care are likely owing to poor diabetes training and expertise, just as I experienced at my nursing home, and also combined with little implementation of diabetes care protocols. I was not given any protocol. I was just supposed to administer medication, and by virtue of using the blood glucose targets, that's the only thing that I was supposed to work with. But aside that, no proper protocol was provided. The lack of agreement on glycemic targets and inconsistent and often unsafe insulin administration regimens. I saw residents being administered with insulin, and then when they felt like not eating, as I've already said, they will snack. And we don't know the effect of all these practices on the outcomes when it comes to older adults in these long-term care facilities. Hence, studies are needed to understand variations in care provided in different residential settings and how that impacts clinical outcomes. Finally, there is a need for more research on good clinical practice in promoting staff education and in reducing hypoglycemia rates in long-term care facilities. This is very important because a lot of the staff don't pay much attention to diabetes management. Yes, when the person is confused, it is just taken as part of old age, and no one is really looking into what is leading to all this confusion, the cognitive impairment, and what is being handed over from one nurse to the other is the resident is confused, and everyone takes it that is as a result of old age. But then could it be that is the improper diabetes management? Because I saw a lot of individuals that they handed over to me as being confused. In conclusion, I will say that there's increasing number of older adults with diabetes, and not just in the US, but all over the world. And there's emerging recognition for the need to provide individualized diabetes management in older adults, because older adults are not all the same. Therefore, more research is needed to improve evidence-based recommendations for diabetes management in older adults. And these are my references for the presentation, and thank you very much for your attention.
Well, thank you so much, Michelle, for that amazing presentation. If you want, thank you for putting your contact information up there. We can leave it up there for a few more moments, and then maybe you can stop sharing so we can see you a little bit better. But thank you. I can see how, did we lose her? Yeah, looks like we might have lost our connection. So we're going to pause for a moment, and hopefully she'll rejoin us. As we're waiting, if you have any questions for Michelle, you're welcome to put them into the chat. You can also raise your hand, and Jenny will unmute you. We are going to do the evaluation after the Q&A and discussion. just for people to be aware of that. We've changed our format for this particular seminar. So I'm sure Jenny's reaching out to her to see what she's up to. Sometimes when you stop sharing, maybe it got disconnected somehow. Thank you to everyone for your patience. If you have any questions, you can type them into the chat so that when Michelle rejoins us, we'll be ready to engage in discussion. As Michelle mentioned, she is finishing up. Today is her very last day of her postdoctoral studies at Villanova. And I'm sure she would share with you too, she's recently moved to Boston. So she's been on the move. Very busy. I know she had a little bit of technical difficulty as we were practicing, but there she comes.
Hello.
Hello. I'm not sure if you heard all of my thank yous, but so I'll repeat that. But thank you so much for an amazing presentation. Very informative, and I can certainly see how the work you did as a PhD student when your dissertation has just, continued to expand and evolve, and your level of scholarship has certainly increased. So thank you so much for sharing all of your expertise and those particular studies with us. There is a question in the chat from Diane. She's asking, how do you feel the newly announced inclusion of diabetes medication on the list of drugs Medicare will start to negotiate price on may impact the issues you discussed with older adults being able to well manage their diabetes? Are you familiar with that at all, Michelle? Or
No, I'm not familiar with that. Yes, I'm not familiar with that.
okay, yeah, so something maybe to look at, because
Yes,
it could
yeah.
be something that not only impacts care, but families may have a lot of questions around that. Oh, and Diane popped the link in the chat, so thank you, Diane, for doing that. So not only can Michelle, but others that might be interested in learning a little bit more about that. So it sounds like Medicare is including certain diabetes medications on their list of drugs where there can be some price negotiation. As we probably, most of us know, diabetes medicines can be very expensive. And especially as you were talking, Michelle, about some of the new technologies with the pumps. Do you have any awareness of whether those are expensive, or if families have difficulty accessing those types of treatments?
Yes, it is. So just, I think some few months ago, that was when some health insurance companies came in to say they would pay for individuals diagnosed with type 2 diabetes to use even the continuous glucose monitors. Previously, it was just individuals diagnosed with type 1 diabetes. And for type 2 diabetes, before they pay for it, you have to be on insulin. But then continuous glucose monitor, the monitors are very good when it comes to diabetes self-management education. The individual gets to know the impact of what they are eating, physical activity, stress on the blood glucose. So why can't we just roll it out for everyone to use? But then, all these challenges are there, and it's expensive if individuals will have to pay out of pocket. So it kind of affects the self-management, which will eventually affect diabetes management. Yes, the overall clinical outcomes.
Well, one of the things that really, captured my attention as you were talking was especially having been a former director of nursing myself in long-term care, was some of your experiences in long-term care as a nurse, as a clinician, as an educator. Sounds like you had many different perspectives that were really important. So in relation to that, I was wondering about a couple of things. One is, I know we really tried to move away from sliding scale insulins. Can you speak a little bit about that? Do you see that a lot still in long-term care or the care of older adults? And why is it that, maybe that's not the best approach?
Yes, I still see it because I think the last time I was at the facility was in January and sliding scales were still being used. So when it comes to the use of sliding scales in older adults, especially with the type of insulin that is being used, I mean, care would have to be taken into consideration when it comes to those kind of insulin because it can easily predispose the individual to developing hypoglycemia, which will eventually lead to other stuff, right? Now there are newer brands of medications that older adults can use when it comes to the management of diabetes, but then it goes back to the cost, right? People are still using the sliding scale because of the cost associated with it. Most of these individuals in the long-term care homes, if it's not being sponsored, then definitely they would have to be on the sliding scale. So that is the challenge that I saw with my practice and even in literature and what I've read. Yes, that is what I know about that.
I also was fascinated by some of the experiences you had as a nurse, in terms of, it seemed like there were challenges related to having the time and the opportunity to provide the proper type of education to older adults with diabetes or to their family members. So if you could design a diabetes education program for long-term care, what would that include from your perspective?
Right. So first of all, I think we need to empower the mostly the healthcare professionals over there because some individuals don't receive updated information on the management of diabetes, and it's just what they know from school that they are still using. And we need to let them know that, hey, we've moved from this point and now we are here. So more knowledge, we need to educate them. And also when it comes to the residents, I was asking my boss, I think the first few weeks that I went to the nursing home, I went back to my mentor who is also into older adults diabetes research. And I was asking, so who is responsible for providing diabetes education in the long-term care facilities? Because I did not see anyone providing diabetes education. And I didn't have the time to do it. You know, the answer that I received, he said, I also don't remember providing anyone with diabetes education. You just go in, do what you are supposed to do, and you leave because the system is structured in such a way that it does not make room for you as a nurse or whoever. You just do your primary goal and that is it. Okay. So when it comes to education, providing any kind of education, I believe that yes, the residents they can equally be empowered. If we are educating and providing diabetes education for the younger population, we can also get something for the older adults, at least let them know the impact of their dietary, physical activity, all these things they have to know. I believe that we can come up with an educational program for them, even though they are over there and the diabetes educators are not getting in the system, something for them to read, maybe a video for them to watch, a game, interaction, online telehealth, something can help, yes, rather than just, providing them with the medication and leaving them like that. I strongly believe in diabetes self-management education and support because once the individual is empowered, they take the diabetes management seriously. Yeah.
Yeah, I mean, you bring up so many excellent points related to education in long-term care, and I don't believe diabetes management is kind of a required annual topic, but certainly something that needs to be updated and making sure people understand current treatments and current situations. Olivia is asking a question: are there still misconceptions among healthcare providers around the hemoglobin A1C guidelines for diabetic management in older adults?
Yes, there are a lot of misconceptions. As I mentioned in my presentation now, we don't really have subgroups when it comes to all these classifications in older adults. And most of the diabetes management, we leave it to the discretion of the attending physician. And so depending on what the provider believes in, that is what they are going to use to manage the condition. And some believe that A1C should be at a certain point, irrespective of the comorbidities, the functional status. They believe that once you are not meeting target, you are supposed to meet target, but that is not it. We've talked about the fact that depending on the group that the individual falls in, there are some that they don't need those tight glycemic management, because at the end of the day, you are predisposing them to hypoglycemia, which will lead to several conditions that we are trying to prevent. So Olivia, yes, there are a lot of healthcare professionals. And I can tell you, I interviewed healthcare professionals not too long ago when it comes to diabetes management, not just in older adult management of diabetes in older adults, but it is surprising that they still hold on to the old stuff that we all thought were important when it comes to diabetes management. Yes, so a lot of people are still there. Mhm.
Yeah, well, and I think that framework you provided with the three groupings of older adults in relation to healthy, complex, intermediate health, very complex or poor health, and how that relates to their A1C levels, their desired A1C targets. That's so critical. And that's a really great example of the type of knowledge that nurses and others working in long-term care need to be aware of. So
we have Marie has her hand raised.
great. Okay.
So.
Oh, sorry. I put it in the chat too. Michelle, thank you so much. I mean, you've accomplished so much in a very short time with your program of research and your clinical work. I think of this from the perspective of education. How well are RNs prepared? You're an expert. How well is the typical RN prepared to care for somebody with diabetes? And is there anything we need to do differently in pre-licensure education?
Thank you. Thank you very much, Dr. Bowles, for the question. I think we have to really emphasize the importance of chronic disease management, not just diabetes. I feel the healthcare system is still structured in such a way that it's just acute. We treat these chronic conditions as acute cases, and it's just medication and then off in the individual's group. But chronic conditions management goes way beyond just taking the medication. And coming back to how to prepare RNs for proper diabetes management, I think we have to emphasize the importance of chronic disease management and then individualizing the care that we provide to individuals. We can't just treat all individuals as the same, but we need to pay attention to their needs, their preferences. I talked about, looking at their functional status, their cognitive. We have to put so many things into practice, and we can get this right from our training. If we believe that these are important, then we need to get this into our curriculum and then prioritize individualized management of conditions, and also providing person-centered. I always come back to person-centered care. We need to prioritize that, yes, in our training.
Great. Thank you so much. I hope you participate in that. You'd be wonderful. Thank you.
Thank you.
Well, are there any other questions? Sarah Songer has a comment. Just thank you for the questions. They really hit the spot, she's saying. So, further explanation about your expertise and how you would improve care for older adults. If anyone has any other questions, you can put them in the chat or raise your hand. I think, I know Michelle has to transition to something else, and we do need to have time for evaluation. So once again, on behalf of our leadership team, I want to thank you so much for this amazing presentation and your time with us today, and good luck. I hope we see you again soon.
Yeah. All right. Bye-bye.